right, so again, I'm Sukhmanjot Kaur. I'm the third-year resident at North Alabama Medical Center, almost graduating, and here's my second presentation. So this was a case of respiratory decompensation, which masquerading the hiatal hernia and gastric volvulus. So, we encountered the common symptoms of hiatal hernia, which include, epigastric, substernal pain, or, postprandial fullness, nausea, retching, and acid reflux. The incidence of hiatal hernia presenting with only the symptoms of dyspnea and orthopnea is reported to be very unusual and is sparsely reported in the literature. So here we present one such case in which dyspnea was initially attributed to COPD, and the diagnosed was revisited during when the patient had a readmission. So we had a 82-year-old female who presented with 1 month history of exertional dyspnea and orthopnea. She had been a lifelong passive smoker, and she worked in a sewing factory. Her physical examination revealed hypoxia, with saturation being 87% on room air. She had some bilateral mild crepitations on chest auscultation. Labs were unremarkable, and her chest X-ray revealed cardiomegaly and a large hiatal hernia. CTA had ruled out PE, but it revealed a large hiatal hernia and changes consistent with COPD. She was admitted with a diagnosis of COPD exacerbation, and she was managed with oxygen supplementation, steroids, bleeding treatments, and antibiotics, with some improvement in the symptoms and subsequent discharge from the hospital. Outpatient pulmonary function testing showed mild airflow obstruction, and 3 weeks later, she presented with worsening symptoms of orthopnea, frequent nighttime awakenings, and throat clearing. On examination, again, she was hypoxic with a saturation of 87% on room air. She had bilateral diffuse crackles. Labs showed leukocytosis of 12,000, BNP 656, and chest X-ray showed an infiltrate involving the right lung base and a large hiatal hernia again. A coronary angiogram showed non-obstructive coronary artery disease without any evidence of heart failure. And the whole reason we went through this angiogram was because we couldn't figure out the reason that was causing all this hypoxic failure, even though, she was getting all the treatment for COPD. So with this additional information, her diagnosis was revised to that of respiratory decompensation due to mechanical complication of large hiatal hernia with possible nocturnal aspiration leading to chronic lung inflammation. Upper GI CDs was done, which showed a very large hiatal hernia without evidence of obstruction. However, she did have partial organoaxial volvulus and severe esophageal dysmotility. In view of her increased risk of torsion and worsening volvulus, the patient was transferred to a tertiary center for her surgical evaluation. So I think the learning objectives from this case is that to describe that hiatal hernia as a condition that causes upper part of the stomach located below the diaphragm to bulge through the esophageal hiatus of the diaphragm into the thorax. And in type 1 hiatal hernia, the GE junction slides along the part of the stomach. And second learning objective is to discuss that more than 95% of the hiatal hernias are type 1, and they rarely cause symptoms except reflux. Rarely, respiratory signs and symptoms can be observed in older patients. This is due to chemical irritation of the upper GI tract, which leads to microaspiration into the respiratory tract, especially in the recumbent position. Additionally, a large hiatal hernia can cause an extrinsic obstruction of the airway and compression within the thorax, exacerbating respiratory symptoms as seen in this case. And next is we need to diagnose large hiatal hernia in a patient mimicking cardiopulmonary disease-related signs and symptoms like orthopnea, PND, and acute type 1 respiratory failure. And there were some few cases that were similar to these, and I've attached some references. And do you guys have any questions?